All right. Hello, everyone. Thank you so much for joining us and welcome to Health for the World Grand Rounds. Today, we have the honor of having Dr. Javad Azadi with us, who will be talking about Introduction to Ultrasound Physics and Artifacts. Dr. Azadi is a renowned radiologist and an acclaimed speaker. He's an assistant professor of radiology at the Johns Hopkins Hospital and also serves as the chief of the ultrasound section. Dr. Azadi completed his medical school and radiology residency training at the Johns Hopkins School of Medicine, followed by a fellowship in body MRI at Johns Hopkins. Dr. Azadi's research focuses on the role of body CT and MRI in evaluating the gastrointestinal and genitourinary systems. Please feel free, everyone, to write your questions in the Q&A box at the bottom of the screen, and we'll get to them in the last 15 minutes of the lecture. Dr. Azadi, it's such an honor to have you with us here today, and we can start whenever you're ready.
All right. Well, thank you for that introduction. Really have nothing else to add. So this is going to be a light talk on ultrasound, specifically about physics and artifacts. This is something that radiology trainees in the US struggle with. A lot of radiologists in practice don't regularly think about these concepts. But I think they're helpful for you as radiologists and radiology trainees to get a refresher for, so that when you're reading these cases, you understand why the images appear the way they do and artifacts that could trip you up. I have no relevant disclosures for this talk. And our learning objective for this talk is to review the basics of ultrasound physics and the artifacts that are associated with those ultrasound physics. So first, let's go into a little bit of history. There are a couple key discoveries that were required before ultrasound as a modality could exist as it does today. The first is the theory of echolocation. This was discovered in the 1700s by Spallanzani, and he was studying bats to see how they can see and how they hear to determine how they fly safely at night. He was able to determine that blinded bats could fly safely. So that would indicate that their eyes were not helping them see, which makes sense, it's dark. However, deaf bats, even if they were deaf in only one ear, couldn't fly. And that implied that hearing was somehow involved in their ability to navigate their environment. This was further refined by Donald Griffin and Robert Galambos, and they were able to determine that bats were generating high frequency sounds that you and I couldn't hear. And these sounds were bouncing off of the surrounding structures, and the bats were able to use those echoes to determine their echolocation. The next discovery was the speed of sound. So the speed of sound, unlike the speed of light, is variable. It depends on the medium that it's traveling through. And the speed of sound is a mechanical wave, not a photon like the rest of radiology. So an experiment was performed by Jean-Daniel Caledon, and he showed that the speed of sound is faster in water than in air. So the experiment was pretty elegant if you think about it. They have two boats 16 kilometers apart. Boat 1 rings an underwater bell, and boat 2 has an underwater receiver to listen for the bell. When boat 2 hears the bell, they light a flash, and then they can determine the time to travel. The speed of sound was measured about 1,400 meters per second, which is very close to what is accepted today, which is 1,482 meters per second. So this differential speed of sound in different materials is why we're able to see, our solid organs very well with ultrasound, but we can't see air-containing structures or calcium-containing structures. The next discovery was Doppler shift and piezoelectricity. So Christian Doppler theorized that the stars in our galaxy appear different due to shifts in the light waves emitted based on the direction the star was moving. So if the star was moving towards us, the waves would be compressed, and if the stars were moving away from us, the waves would be broadened. And all of us experience this every day, even if you don't think about it. Your patients will experience this whenever there's an ambulance or some kind of siren. As that siren moves towards us, it sounds higher frequency, and as it moves away, it becomes lower frequency. This allows us then to take advantage of the Doppler effect to determine velocity and direction. Jacques and Pierre Curie discovered that crystals can generate electricity when pressure is applied. And then alternatively, those crystals will generate pressure when electricity is applied. This is known as piezoelectricity. And so you can see in this graphic here, as the crystal is compressed, there is a change in voltage. So those discoveries altogether allowed for ultrasound to be the imaging modality as we know it today. So ultrasound wasn't always as we know it. It wasn't, you have an ultrasound probe, you stick it on a patient, you get an image. The initial ultrasound was actually a transmission method. And transducers were placed on both sides of the patient's head, and the patient's head was partially submerged to facilitate transmission of the sound waves. The changes in sound waves were then measured on heat-sensitive paper. And so our first real application in ultrasound in medicine was to measure the size of the ventricles of the brain in patients with brain tumors. We didn't have a reliable way to look at the ventricles. This was before CT or MRI. Pneumocephalography, I guess, is a technique we could have used, but it's invasive, and from what I've heard, it's painful. Thankfully, we don't use it today. So as the sound waves travel through the skull, there are going to be differences in intensity, and that those changes will reflect whether or not a patient has obstructive hydrocephalus or not. This technique was very prone to artifacts. We don't use it at all today, as far as I know. So what do we use today? We use pulse echo ultrasound, and there are 4 modes that we regularly use. The transducer both sends and receives sound waves to generate diagnostic images. This is just a schematic for what a generic ultrasound transducer looks like. It has a wire going to the actual probe, and that's to transmit and receive the sound waves. There's plastic housing. There's a dampening block to reduce the echoes posterior to the piezoelectric element. And then there's some matching layers. And basically what it's able to do is it's able to send echoes out, and then the echoes bounce back. They hit the piezoelectric element, and then they can be read out. The computer does a lot of the, or actually does all of the post-processing, and is able to give us real-time images. So the first mode to talk about would be A mode, or amplitude mode. It's a one-dimensional measurement of the reflected sound waves. The amplitude would be plotted against the echo time, and it can determine the dimensions of an organ be imaged. I personally have never used A mode imaging, but I know that it's useful in ophthalmology to determine the length of the globe as well as to detect masses. So ophthalmologists will use this in patients with diabetes or who have risk for retinal tumors. B mode, now this is our bread and butter. If you've ever used ultrasound in radiology, this is what you most likely have used. If you've used ultrasound outside of radiology, similarly, this is what you would have used. This is what point of care ultrasound really leans heavily on. This generates a 2-dimensional anatomic image. The first component of the image, the brightness, is based on the strength of the returning echo. So the more echo that returns, the brighter it appears. And then the position on the screen, how deep it is from the probe, depends on the transit time. So the longer it takes to get back to the probe, the deeper it's going to appear on the image. So this real-time anatomic imaging is possible just due to the fact that the transducers are very advanced today. This is just an example of a B mode image, very classic example of gallstones and the gallbladder. So you're able to scan the gallbladder in real time, assess for gallbladder wall thickening, tenderness. It is an interactive exam, unlike a CT or an MRI. Certainly used for problem solving, although with our contrast shortages globally, maybe it's going to be in the short term taking over for diagnostic applications. And in areas where a CT or MRI may be harder to obtain, ultrasound certainly is a suitable replacement for a lot of indications. M mode is the motion mode. It's able to evaluate changes in echo amplitudes over time in the beam path. And this is helpful because moving structures are going to have varying amplitudes, while stationary structures will have flat amplitudes. So we use this a lot in our first trimester ultrasounds to determine if there's fetal cardiac activity. This could also be helpful to measure cardiac anatomy to see how valves open and close. This is just an example of how we would determine fetal cardiac activity. And so where the periodicity occurs, that's going to reflect a cardiac cycle. And then you can measure how long it takes between each beat. And that can be then used to derive a fetal heart rate. And then finally, Doppler. Doppler requires the Doppler principle, and ultrasound can measure the Doppler shift to determine the direction of velocity of motion in a beam mode image. So Doppler can be superimposed on a beam mode image. Doppler can be attained without the beam mode, but it's a little less useful if you don't know what you're measuring it is. Spectral Doppler allows us to plot changing velocities over time to determine waveforms. So this is very helpful if you see something vascular and you want to know if it's arterial, venous, or just kind of noise from something flowing, because not all Doppler signal is blood flow. And then power Doppler is a very common application. There are more advanced techniques like superb microvascular imaging. They're vendor specific. I don't go into them in this talk, but they're able to, really look at the fine microvasculature. For day-to-day radiology practices, that's not useful. Power Doppler, however, is, and that's because it's extremely sensitive for flow. And that's because it discards the direction. And so it can detect flow at very, very low velocity. So if you want to prove that, say, a carotid artery is completely occluded, you would apply power Doppler. Whereas if you were to apply just regular color Doppler, it may appear occluded. And this is just an example of renal artery duplex. This is a nice technique that we can look for renal artery stenosis, for causes of secondary hypertension or primary hypertension. Similarly, it can be useful for evaluating transplants. So, a lot of patients in the United States get renal transplants, and this is the go-to modality for determining graft health. And another example would be for power Doppler, would be to look at the scrotum and testicles in patients with acute scrotal pain. The concern would be that a patient has experienced torsion where the vascular supply is cut off. Ultrasound is a very nice, non-invasive, quick modality to confirm or refute that diagnosis by showing there is or is not blood flow. In this case, power Doppler was used, and it shows there's an abundant amount of blood flow. And that would support, rather there being ischemia, that there might be orchitis, so inflammatory infectious etiology in the testicle. Transducers have come a long way since those initial transmission methods. The three that you really work with in a practice are linear, and those are really great for near field resolution. So think about looking at musculoskeletal applications, looking at tendons, looking at subcutaneous collections. Curves are good for deeper exams. So those are kind of your general all-around ultrasound probes. If you only had to have one, you'd want a curved. And then finally, there are phased array probes, and these are smaller probe size. They're specialized. They can really, uniquely arrange the piezoelectric elements so that you can get into a small space, you can steer, and you can image things you otherwise wouldn't be able to see. So examples would be transesophageal echo, right? The echo is in the esophagus, or transvaginal ultrasound or transrectal ultrasound, where you have a little bit tighter spaces. But the engineering in these is fantastic. The one takeaway from this is, as the resolution improves, the depth decreases. So higher frequency probes will have better near field resolution, but they can't go as deep. And that's because the sound waves are dampened as they go deeper and deeper. All right, so we're going to change gears a little bit and talk about ultrasound physics. So we've talked about how the science that went into making ultrasound probes. We've talked about the various types of probes, but let's actually kind of dig a little bit deeper into how this works. So the velocity is dependent on the frequency and the wavelength. And for sound waves, the frequency or the velocity can change. And as a result, the frequency is kept constant and the wavelength changes. And what happens is the transducer is emitting sound waves, and these are pressure differences. And you're going to have areas of compression and you're going to have areas of refraction. And so you need to have this full cycle in order to resolve what you're trying to see. So you can't resolve things smaller. And these sound waves interact with the tissue as it travels through, and the echoes that being received are the sound waves being reflected back. So if the sound waves just traveled through, there would be no signal. And if all the echoes reflected back, there would be a very bright signal. The physical principle is called acoustic impedance. And so the acoustic impedance is related to the density of the tissue. And so the denser the tissue, the more impedance there is. There are scattered echoes when it bounces back. It's not a, just it comes over, it comes back. It can come over and come off angle. And that can actually cause artifacts, which we'll discuss in a little bit. So it's not everything that you're seeing in the field of view is actually truly in the field of view. I think vendors do a good job of reducing these off-angle sound waves, but they can still pose problems. How do we shape the pulse? Well, so the ultrasound pulses are generated by applying electrical waveforms to the piezoelectric elements. Those elements then vibrate and are going to emit high frequency sound waves. The echoes are going to be then detected when reflected sound waves reach the piezoelectric elements and vibrate them slightly. The vibrations are converted by the piezoelectric material into electrical signals. So you can think of it going electricity, vibrations, echoes, vibrations, electricity. The sound waves being generated, there's a form of a primary beam, and that's the beam that's going to be used to image what you're trying to see. There's this concept of the Fresnel zone or the Fraunhofer zone. This is just if you're above or below the focal spot. Really what you're trying to image, you want it to be at the focal spot where the beams are converging or at their convergent point. These side lobe echoes cause artifacts. And so how do we scan the ultrasound beam? Well, transducers are actually made up of numerous arrays of piezoelectric elements. It's not just one single piezoelectric element, as I kind of alluded to earlier. So you can individually trigger or individually listen. You can shape the beam. Again, this is more engineering than it is radiology, but in a linear array transducer, the ultrasound beam is actually created by electrically exciting only a subset of these elements. The ultrasound pulse is emitted perpendicular to the array and is centered over the element subset. And then the ultrasound beam shifts across the array during imaging so that the field can be efficiently scanned. And since this occurs in 1/10 of a second, you're able to get multiple samples of the field. And because you're getting multiple samples of the field over time, you're able to actually get temporal resolution so you can see things in real time. So it's not like you get a snapshot like with a radiograph, you have real-time imaging. So the echoes are being sent out, the echoes are returning. In an ideal world, all the echoes would be the same intensity as they returned, but because you're traveling through a medium, the medium is a sound dampener. And as it gets deeper and deeper, the intensity decreases. And so the lines are going to become fainter and fainter. And so the machine will kind of compensate that with time gain compensation. So deeper structures will have increased signal, but that can also create artifacts. For the most part, machines now automatically do it, but older machines, you can manually set the time gain compensation. The machine is going to receive the echoes, it's going to process them. So the signal is uniformly preamplified immediately after detection by the transducer. And then the machine will use time gain compensation to ensure the deeper structures are accurately displayed, more just so you can see them. So patients who are obese, patients who have ascites, who have increased abdominal circumference, ultrasound becomes less useful than if you have a very skinny patient. This in turn is why we're able to use ultrasound very, very well in pediatric patients to diagnose something like appendicitis, Whereas with an elderly patient who's obese, you would rather than get a CT scan. For the Doppler principles, so Doppler signal is related to the angle of measurement due to cosine theta in the Doppler equation, which is written here. I've never memorized that actual equation. I just understand that the angle is going to determine whether or not your velocity measurement is accurate or not. So if the angle is 90 degrees, which means it's perpendicular to the blood flow, the shift goes to 0, so it can't measure any Doppler shift. 60 degrees to blood flow is ideal. If you have angle less than 20 degrees, it actually leads to artifacts, including aliasing. Thankfully, power Doppler has no angle dependence, and power Doppler doesn't have any aliasing. That's just because it's showing you, is there flow or not? It's not telling you the direction or velocity. So a few more Doppler concepts, just because it's kind of helpful that this is something that you can really only get from ultrasound. So for vascular waveforms, there can be triphasic waveforms, biphasic waveforms, or monophasic waveforms. And what triphasic means is it has 3 phases, and that's because it crosses 0 flow baseline twice in each cardiac cycle. So there's systolic forward flow, early diastolic flow reversal, so that's below the 0 velocity baseline, and then late diastolic forward flow, so that's slower than in systole. Biphasic means that it has 2 phases or variations of forward and reverse flow. So it can have systolic forward flow and then either diastolic flow reversal without late diastolic forward flow. So that's a lot more common, or just no 0 diastolic flow reversal and pan diastolic forward flow. So it's slower than in systole. And then finally, monophasic, having 1 phase. So there's systolic forward flow continuing to diastole. There's no reversal diastolic flow, and they can be divided by acceleration or deceleration time. So a sharp acceleration time is going to have a fast systolic rise and fast diastolic flow, whereas a blunted acceleration time is going to be a slow systolic rise and slow diastolic flow. And that can be helpful to determine if there's stenosis or some abnormal pathology in the vessel. Triphasic arterial flow is considered normal in peripheral arteries, and monophasic flow is considered abnormal. There's some controversy surrounding the definition of biphasic, so there's disagreement whether biphasic flow is normal or not. Diastolic flow reversal is generally normal, but pan-diastolic forward flow in arteries and the extremity arteries is abnormal. This is different than for the brain and the visceral circulations, and these are lower circulation, or rather lower resistance organs. And if you think about it, just kind of from basic principles, if the brain has a temporary cessation of blood flow, that's an ischemic event, and that can cause, transient ischemic attacks or even stroke. So that's, want to avoid that. And the kidneys, similarly, are continuously perfused. So that differs from, skeletal muscle in the extremities, which, should be metabolically inactive for all purposes when not in use. And then for venous, pulsatile venous flow is considered abnormal, and it's suggested of elevated pressures in the right atrium. So this is just an example of normal triphasic waveform. So it comes up, comes down, comes back up. You can measure peak systolic velocity and diastolic velocities. So low resistant vessels like the internal carotid artery, renal artery supply end organs. So these will have high diastolic flow and high end diastolic velocities. So high resistant vessels are characterized by early reversal of diastolic flow, and they'll have lower absent and diastolic velocities. So in stenosis, a localized reduction in the vascular radius will increase the resistance. So you're going to have a marked increase in peak systolic velocity and diastolic velocity distal to the stenosis. And the degree of stenosis generally corresponds to the degree of increased peak systolic velocity and diastolic velocity. So this becomes a little unreliable in near occlusion, so 99 to 100%, because the velocities can appear high, they can appear low, or appear absent. So in those cases, that's where power Doppler really shines. And there can actually be a significant reduction in post-stenotic flow velocity. That's called trickle flow. In order to diagnose complete occlusion, you would want to have absent peak systolic and diastolic velocity. You can calculate resistive indices from spectral Doppler. And it's usually used to assess resistive or pulsatility in a vascular system. Resistive index is defined as the peak systolic velocity minus the end diastolic velocity over the peak systolic velocity. It's a very common application in vascular ultrasound, and we use it a lot for transplant, renal and liver exams to assess whether or not the arteries are patent or stenotic. And as the RI goes up or the RI goes down, that can be a predictor of thrombosis or graft rejection, and it's very helpful for management. The resistive indices reflect vessel resistance. So as a vessel narrows, the resistance to flow increases, so the RI increases. It's also proportional to vascular compliance, but that's not something that I think about. And then laminar flow. So in a straight pipe of a constant diameter, the density, the velocity, and the diameter of the pipe are related to the flow, and it has a parabolic flow profile. So each layer has increasing velocity. So the center has the fastest velocity and the periphery has the lowest velocity. This is useful because in vascular stenosis, the blood velocity is increased at the stenosis, but there's post-stenotic turbulence and flow separation. So there's going to be an increased range of blood velocity. So that's what that spectral broadening is. Turbulent flow is bad. If it's present, it can cause endothelial shear stress and it can promote thrombosis. Acceleration times is another parameter that we can measure. It is helpful in assessing renal artery stenosis in Doppler ultrasound. It's the time that it's startup systole to peak systole. For renal arteries, it's usually less, or intrarenal renal arteries, it's usually less than 70 milliseconds is normal. All right, so now let's touch on some ultrasound artifacts. So there are 6 key assumptions in ultrasound, and the artifacts generally derive from the fact that these assumptions are violated. So the first assumption is that echoes detected originated from within the main ultrasound beam. We've already kind of alluded to that's not always the case. The second is an echo will return to the transducer after a single reflection. The third is the depth of an object is directly related to the amount of time for an ultrasound pulse to return to the transducer as an echo. The fourth is the speed of sound in human tissue is constant. The fifth is the sound beam and its echo travel in a straight path. And then finally, the acoustic energy in an ultrasound field is uniformly attenuated. So for the first assumption, echoes detected originated from within the main ultrasound beam path. The reality is that the ultrasound beam is a complex 3-dimensional shape. So there are a lot of additional lower energy off-axis beams, so side lobes, grating lobes. So these echoes, if they were to return back to the transducer, would create the appearance of something in the focal zone. So this is known as beam width artifact. So the ultrasound beam exits the transducer, narrows, and then it widens. And the distal beam can widen beyond the actual width of the transducer. And so if there's a highly reflective object located distal to that beam, can generate detectable echoes leading to artifacts. So if you suspect that's the case, just change the planes or change the focal zone. So you see in this case, we move the focal zone to match where the finding is, and the artifact disappears. Side lobe artifact occurs when there are strong reflectors in the side lobe beams, and so they create echoes as well, and it looks like it originates within the main beam path. So this can be tricky because it can cause you to think there's clots, maybe make you think that there are stones when there are no stones or masses. Color Doppler will be helpful to show that this is an artifact because these findings will fill in if you're doing vascular ultrasound. So the next assumption is an echo returns to the transducer after a single reflection, and the depth of an object is directly related to the amount of time for an ultrasound pulse to return to the transducer as an echo. The reality is the echoes generated from a primary ultrasound pulse may be repeatedly reflected back and forth before reaching the transducer again. So just as it reflects when it goes down, it can reflect when it's coming back, and it can actually get stuck. And this is what causes reverberation artifact. So the multiple echoes are recorded and erroneously displayed, but only the echo that returns first is in the correct location. So all these deeper ones are fake. The sequential echoes take longer to return to the transducer, so they're going to be placed lower or deeper and deeper. And you can generally detect if that's the case because they're equally spaced lines on the image, and that doesn't make sense anatomically. Comet tail artifact is a type of reverberation artifact, and you see this with closely spaced reflective interfaces that cause sequential echoes. The unit may not be able to process these as distinct, so they blur together. It's kind of like comet tail that you see with thyroid nodules or cholesterol crystals in the gallbladder wall. It's a helpful artifact to determine if something is worrisome or not. The later echoes similarly will have decreased strength due to attenuation, so they give it that characteristic comet tail shape. Another reverberation is ring down. And so it's similar but different. The ultrasound pulse is going to resonate within fluid trap between some air bubbles, and these vibrations cause a continuous sound wave that is transmitted back to it. So instead of it being equidistant lines, it's a kind of a sound wave that just goes all the way to the bottom. This is helpful to determine if there's fluid or gas in a collection. It can contribute to dirty shadowing. Mirror imaging artifacts can be generated by the false assumption that the echo returns to the transducer after a single reflection. And so the echo is reflected and counted the backside of a structure and reflected back towards the interface. And so usually you'll see this at the diaphragm, and it's easily identifiable. Interestingly enough, the Doppler signal will also be mirrored. And this can be avoided by decreasing the gain of the ultrasound. So some artifacts associated with the velocity errors. So the assumption is that the speed of sound in human tissue is a constant, but in reality, the speed of sound depends on the material, and the material is dependent on its density and its elastic properties. So air is poor, bone is poor, but fat and soft tissue have slightly different speeds. And so if you're imaging a fatty liver, or you have an area of focal fat, the posterior portion of the liver can appear discontinuous due to areas where the sound beams travel faster than the rest of the organ, where they travel slower, and so you have discontinuous echoes. And so this can cause you to falsely diagnose cirrhosis when in reality the patient just has fatty liver. Refraction artifact. So the assumption is the sound beam and its echo travel in a straight path. The reality is a change in velocity of the ultrasound beam as it travels through two adjacent tissues with different density and elastic properties may result in refraction. And so refraction is when a non-perpendicular incident ultrasound energy encounters an interface between two materials with different speeds of sound. The incident ultrasound beam can change direction. So the degree of this change in direction is dependent on both the angle of the incident ultrasound beam and the difference in velocity between the two media. So generally this leads to impossible anatomic appearances. I'll see this, the trachea looks like it's flipped with like the thyroid, or you're doing an ultrasound of the aorta, and like the aorta is in the wrong spot. So if you note, it just changed the imaging plane, it should correct. Artifacts associated with attenuation errors. So the reality is ultrasound beam travels through the body, the energy becomes attenuated secondary to absorption and scatter. And so an echo that travels a greater distance, the body will be attenuated more than an echo of similar energy that travels a shorter path. And so these ultrasound machines are going to incorporate compensation amplification so that it knows that echoes that take longer to return should get more amplification. Time gain compensation is just a user adjustable form of this compensation. The attenuation coefficient expresses loss of ultrasound intensity per distance traveled and varies in different mediums. So a fatty organ will have a different attenuation than just a pure soft tissue. Shadowing artifact is something that you'll see all the time. So if a pulse encounters a strongly attenuating or highly reflective structure, the amplitude of the pulse distal to the structure is going to be completely diminished. So the echoes returning are going to be highly attenuated, will also be diminished. So this causes shadowing behind the structure. So you can see this cardiac leads, calcifications, see with gallstones, anything that's densely calcified. So you can't really see behind calcification. The Doppler signal should be also be shadowed. So if you encounter, you just have to change the imaging plane. Increase through transmission is the corollary to this. So if the pulse encounters a weakly attenuating structure like fluid, the amplitude of the pulse behind this is actually going to be greater than the beam at the same depth the rest of the field. And that's because the echoes returning from the structure deep to the focal weak attenuator are actually going to be higher amplitude and appear falsely increased echogenicity. So this is really helpful to decide if something is fluid containing or not. So you have something that you're not sure is a cyst or solid because it's really hypoechoic. You really want to see that increase through transmission. So these are my references. I leaned very heavily on the ultrasound artifacts paper by Feldman. The physics tutorial for residents and radiographics from 2003 was also very helpful. If you just want to learn more about the history of ultrasound from bats and boats to bedside and beyond by RSNA, that's very helpful. And then Radiopedia for my cases. And with that, I can turn it over, I think, to questions.
Thank you so much for the amazing lecture. Please feel free to write your questions in the Q&A box at the bottom of the screen, or you can also write them in the chat box. No questions yet. We'll wait a few more minutes for questions. Please write your questions in the Q&A box. All right, seems like.
All right. Well, you know, if you have questions, you know, those articles that I mentioned are very helpful. It's definitely something to be aware of. And thank you for the wonderful lecture. No questions. Thanks again. But it's definitely something that to be aware of to make you a better ultrasound radiologist.
Awesome. Thank you so much.
All right. Thank you, guys.